Come on, you guys are the best of the best in the world. Namaste, everyone.
Whoa, whoa. Shine your light.
Somewhere along our journey of being humans, we have forgotten that we are not the only species on this planet. We are just one among millions and millions of species on this planet.
Whoa, whoa. Whoa, whoa. Whoa, whoa. Whoa, whoa. We are all in this together. We are all in this together. And nothing can remind us like a simple act of kindness. Hey! And in the blackest of night, just one flash of light shows we're not alone. No, not today. It is time. Let's do this. It's our time. Let's do this. It is time to shine your light. Let's do this. It is time to shine your light.
We only protect things that we love. So we should all make it our mission to make everyone fall in love with the natural world. And hopefully through that love, we will clean, protect and conserve.
It is time. Shine your light.
मैं जो साथ निभाऊं, तू जो साथ निभाए, तो बात बन जाए, तो ये रात ढल जाए. चलो हाथ बढ़ाएं, चलो सबको दिखाएं, कोई भी यहाँ अकेला ना है.
It is time. Let's do this. It's our time. Let's do this. It is time to shine your light. Let's do this. It is time to shine your light. Come on. Whoa, 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 whoa.
The pain and suffering that we inflict on the environment and nature is pain and suffering that will eventually be inflicted on us as a species. And we need to start thinking as a species.
It is time. Let's do this. It's our time. Let's do this. It is time to shine your light. It is time. Let's do this. It's our time. Let's do this. It is time to shine your light.
We do not inherit this world from our ancestors, but we borrow it from our children.
Shine your light.
Thank you and good night.
Good evening, friends. Today evening is a special occasion when we are celebrating the World Hearing Day. And as you know, this year's theme has been a very special theme where we say things which are important. As you know, more than 5% of the global population lives with hearing loss due to a combination of current lifestyles and a lack of awareness about the dangers of listening to loud sounds. That percentage is likely to increase in the coming years. Exposure to loud sounds may occur in occupational, environmental, or recreational settings. Also, this is a fact that 430 million of the world's population has hearing loss that affects their quality of life. The majority of these people live in low and middle income countries like India. It is estimated that by 2050, this number could increase by over 50% to 700 million. And these numbers refer to people with hearing loss greater than 35 decibels in their better hearing ear, meaning that only sounds louder than 35 decibels can be heard. And 35 decibels is approximately the sound level of a loud whisper close to the listener. Normal hearing has a threshold of 20 decibels. Hearing loss at the 35 decibel level is commonly termed disabling hearing loss, and some common terms used when referring to people are multiple terminologies are used. Of those with hearing loss, 80% live in low and middle income countries like India, where services required for their care are commonly lacking. Hearing loss has far-reaching social and economic repercussions. Unaddressed hearing loss results in an annual global cost of $980 billion. So today, on World Hearing Day, a special session of Enoch DigiConnect webinar is being held. The theme, as you know, of World Hearing Day 2022 is to hear for life, listen with care. And on this occasion, we have invited Dr. Malik, the consultant ENT, head and neck and robotic and cochlear implant surgery surgeon at Apollo Hospitals, that is the Indraprastha Apollo Hospitals, New Delhi. I should share with you some background information about Dr. Malik. He is currently working, as I told you, in Indraprastha Apollo Hospital, New Delhi since 2015 as a consultant ENT head and robotic and cochlear implant surgeon. He completed a master's of surgery in ENT from Government Medical College, Jammu, and then was in Safdarjung Hospital, which is a central government hospital in New Delhi, for 3 years as senior resident, and had work experience of Max Specialty Hospital in Saket, New Delhi, and Batra Hospital, Jammu. Dr. Noor specialized in diseases of ear, nose, and throat, and complicated cases of skull surgery and head and neck cancers. He has experience in micro ear surgery, endoscopic sinus surgery, surgery for sleep apnea, which is through robotic technology, microlaryngeal surgery, and head and neck surgery. He has been invited as a faculty for presentation on robotic tongue-based reduction in Indian Association of Surgeons for Sleep Apnea in 2017. He had conducted hands-on advanced robotic head and neck surgery workshop at PGI Chandigarh in 2017. He was also invited as faculty in nasal endoscopic sinus surgery workshop in Narayana Hospital in Jammu in August 2018. So without wasting much more time, I would like Dr. Malik to share with you our special session on hearing loss. Dr. Malik, please.
Good evening, everyone. At the outset, I would like to thank Indian Association of Occupational Health Delhi chapter for the invite in this. I feel privileged to be part of this. So that Dr. I think Rajiv Kumar Jain sir has already given us an overview of the burden of hearing loss globally as well as in India and its implications. So today I would be talking about hearing loss because it's a hearing 3rd March is a hearing day, so we have to discuss something. It's an important sense organ. Hearing is an important sense organ. So will be discussing a little bit about the hearing loss. Yeah. So what is actually hearing? Hearing and the auditory perception is basically perceiving sounds by detecting vibrations or changes in the surrounding medium through time and through our ears. So our ears are basically, we divide ears into external ear and middle ear and inner ear. So whatever we perceive the sound, it goes through an external ear, then the eardrum, and then there is a component called as middle ear behind the eardrum, and from middle ear, there are 3 small bones which are called ossicles. So the sound is conducted into the inner ear, and from there our brain perceives the sound. So this is how the hearing happens. So next, please. So to understand the mechanism or the physiology of hearing, we need a sound stimulus. Then the sound is again conducted. There is a conduction of sound through the ear into the external ear canal and on. Then again it goes to the eardrum and through the ossicles into the inner ear. From there, the transduction of sound happens, which is carried by the this hearing nerve into the brain cortex, from where the encoding of signals happens and we hear the sound. This is the mechanism of hearing in general. Next, please. So if we talk about hearing loss, it is a surprising thing that is even more prevalent than diabetes mellitus and other medical issues also. There are a lot of medical and other conditions which we think they are in the epidemic scale, but hearing loss is more prevalent than even diabetes mellitus. This is a very surprising thing. And as far as the sensory deficit in humans is concerned, it is the most common sensory deficit in humans as of now. And as per as WHO estimates, around 6.3% Indian population, they are suffering from significant auditory impairment or the hearing loss. And it is more common in the children between age of 0 to, the newborns to 14 years of age. So if a WHO classification of hearing loss, if it is between less than 25 decibels, we consider it as normal and there's no hearing impairment. Then 26 to 40 decibels, we consider it as mild hearing loss. And then moderate is 41 to 60 decibels. And then severe hearing loss is between 61 to 80 decibels. And then we call it as profound hearing loss if it is more than 81 decibels. So there are different ways to classify hearing loss. When it can be unilateral or bilateral. And then there are other types also, like conductive hearing loss and mixed hearing loss and the sensorineural hearing loss. So conductive hearing loss is when there is a defect in the conduction mechanism of sound, which passes through the ear canal into the eardrum and ear ossicles and then in the ear. So the causes could be because of some abnormal formation of pinna. That at times this pinna formation is not there. This canal is congenitally blocked. We call it as microtia or anotia. And at times there is wax which is completely blocking. A lot of people have this wax formation which is genetically determined, and there is an accumulation of wax which blocks the ear, this conduction of sound. Foreign bodies, pediatric age group, some children have a tendency to fill the orifices. Sometimes they can have these foreign bodies in the ear. Then we have tympanic membrane perforations, sometimes fluid in the middle ear, it's called effusion. And last but not the least, the 3 small bones in the body in the middle ear which vibrate and which move after a sound strikes the eardrum and we listen to the sound. Sometimes they get fixed because of diseases like otosclerosis, tympanosclerosis that could cause hearing loss. And similarly, the other type of hearing loss is because of inner ear damage or the pathways to the brain which carry the sound signal. So that because of that, it can happen. That is called sensorineural hearing loss. So it can happen before birth also, intrauterine life also, or after birth, which is called as acquired hearing loss. So geriatric population in elderlies I mean, it is a significant burden and a cause of, social isolation and depression also. I mean, it needs a lot of concern. This phenomenon is called presbycusis, or age-related hearing loss, and usually affects adults which are more than 50 years or 60 years of age, and it causes the problems, significant association with other conditions like dementia, and history of falls is there, and again they go into, because of lack of communication, they go into social isolation and depression, which needs to be addressed. And it is usually, if you see an audiogram, which is the diagrammatic representation of how we hear the sounds in all different frequencies. So usually you'll find, because of presbycusis, there'll be a high frequency dip in the audiogram, so which denotes presbycusis. So as far as children are concerned, difficulty in hearing in children it's a very common thing, and because of that, what happens is their speech and language development is affected. In future, if their speech and languages development does not happen, it has implications on their life, how they get into, how they study. It affects their studies and ultimately employment and their social well-being also. So because keeping this in mind, there was a universal neonatal screening program which was started, and because of that, 74% are being diagnosed and received intervention before 6 months, by 6 months of age. The goal is universal screening and detecting hearing loss prior to 3 months of age, and again initiating the appropriate intervention just prior to 6 months of age when a child is born. So now we come to the causes of hearing loss. There are genetic causes of, we classify into many parts of the, one of them is genetic causes, so which accounts for around 50% of hearing loss in pediatric age group. The genetic causes could be syndromic and non-syndromic. It can be that hearing loss can be associated with other anomalies also, like in syndromic hearing loss. So few of the examples are already mentioned there, like Waardenburg syndrome, Garnet syndrome, and Treacher-Collins syndrome, Turner syndrome, Klinefelter syndrome. I won't get into details of these syndromes, but generally these are the syndromes which are usually causing associated hearing loss along with other anomalies. So the other causes include, next please. Antenatal causes are very common, and they usually account for 5 to 10% of hearing loss, and usually because of the congenital infections like viral infections like cytomegalovirus, herpes virus, and these are preventable. Just please note that herpes, rubella, syphilis, toxoplasma, and varicella. So similarly fetal exposure to teratogens like mothers taking methyl mercury, retinoic acid, thalidomide may also result in sensorineural hearing loss in pediatric in children. Third cause is perinatal, which accounts for 5 to 15% of hearing loss. This is after birth, and usually premature children, low birth weight, less than 1500 grams, anoxia, birth anoxia, or low Apgar scores, and hyperbilirubinemia, and in any kind of infection, general sepsis. This also leads to sensorineural hearing loss, and those children, they are high risk group of children which need neonates, which need screening and intervention at the earliest. So next is post-natal causes, which are around 10 to 20%. They account for hearing loss, and they include childhood infection like mumps and meningitis, and treatment with ototoxic medication like aminoglycoside or furosemide, and otitis media or major head injuries. They can cause either conductive hearing loss or sensorineural both. So the study by Schiffer et al. It suggested iron deficiency anemia was associated with increased risk of sensorineural hearing loss in children and adolescents. So what are the high risk criteria for hearing loss in neonates and infants? Is if there is a family history of congenital or early sensorineural hearing loss, congenital infections, just as I already discussed, like toxoplasma, cytomegalovirus, Some kids are born with craniofacial anomalies. They have this risk of sensorineural hearing loss. Hyperbilirubinemia, like jaundice after birth, low birth weight, less than 1500 grams, bacterial meningitis, exposure to ototoxic drugs, and low Apgar scores. And some kids, they are on prolonged ventilation also. They require after birth, they require ICU care. So those are especially at risk of sensorineural hearing loss, and of course, and not to forget syndromes associated with sensorineural hearing loss. So for infants who are 29 to 2 years of age, so the concern about hearing, speech, and language development delay, so that there are chances of at times bacterial meningitis. So all these things, there are neurodegenerative disorders in usually pediatric neurologist. They are it's basically a multidisciplinary to diagnose at the earliest sensorineural hearing loss and at the same time intervene so that this development and speech development happens normally. So physical examination, pediatric age group, particularly congenital, whom we consider for congenital hearing loss, carefully, we have to examine them and associate. For example, if we are suspecting some congenital hearing loss because of some syndromes, particularly like Waardenburg syndrome, there will be a white forelock here, and the color of iris is different in such patients. We have to examine their ear canals for any impacted foreign bodies, cerumen. Sometimes we have to rule out any effusion that is behind the eardrum if there is any accumulation of fluid by using pneumatic otoscopy, and sometimes congenital cholesteatoma, which is again a bone eroding which has bone eroding properties, that needs to be ruled out. And similarly, head and neck examination to rule out other abnormalities and craniofacial malformations, and these are important. So what do we do in specific this neonatal screening program? What we do is we go for otoacoustic emissions at if there is a refer in otoacoustic emissions, usually it is done 24 to 72 hours after birth. And if there is a refer, so we again do it after 2 weeks. Same otoacoustic emissions. If there is a refer again in otoacoustic emissions, then we after 2 weeks we go for auditory brainstem response. But if there is a if it is pass, then no need of intervention. And usually 6 months of age we get the ABR and we see how much is the degree of hearing loss. Audiometry, of course, is an option, but it is usually done after 4 to 5 years of age when there is a response from the kids. So sometimes brain imaging is also of importance. Sometimes we see the vestibular aqueduct, and there are some kids who develop meningitis. In them, we see if there is an ossification in cochlea. So, and there are malformations of cochlea and cochlear nerve, whether it is present or absent. So there are certain kids whom the cochlear nerve is absent. In those, even the cochlear implant is of not of any benefit, and even amplifying using a hearing aid will not help. There are other means of then we go ahead and we check them for auditory brainstem implants and all those things. So as far as the treatment part is concerned in hearing loss, there is a medical treatment which is usually helpful in conductive hearing loss, like removal of any obstruction or blockage like wax, foreign bodies. Sometimes there is effusion in the middle ear. We have to rule out in pediatric age group adenoids, which are behind the nose where eustachian tube drains. So sometimes that needs to be addressed. But if it is the serous otitis media or effusion is more than 3 months, then sometimes we have to drain that fluid called laryngotomy, and we have to put ventilation tubes. Sensorineural hearing loss, as far as it is concerned, there is no medical treatment, unfortunately, for that. But in mild to moderate, but it can be amplified. If it is mild to moderate hearing loss is there, we use hearing aids and it can be easily amplified. And these children do very well after that. Also, there's a language and speech development is normal. But if the hearing loss is beyond, severe to profound, then even sometimes these are also not helpful. So in those cases, what we do is where we go ahead and prepare them for cochlear implantation. Cochlear implantation, it does not amplify the sound, but it directly stimulates the cochlear nerve by using electronic signals, and there is an post-operative rehabilitation for a year, and those child do very well after then if implanted at the right age. So there are two goals of amplification in pediatric age group using hearing aid. One is to provide the language, and if brain does not listen to sound, speech the will not never develop. So we have to, that is the main purpose of amplification. So second goal of amplification is to provide environmental cues, and uh, unless the child hears a sound, the speech and language will not develop. So that's very important. So as far as conductive hearing loss is concerned, again, as I told, if there is an effusion lasting for more than 3 months, then we remove that, drain the fluid, we put a ventilation tube, it gets fixed. Again, in adults, in pediatric age group, if the 3 ossicles are 3 bones, small bones, if there is a fixity, we go for ossiculoplasty. And sometimes there are conditions called otosclerosis, wherein there is a small bone, smallest bone in the body called stapes, which gets fixed. And we remove that one part of that bone, and we just put in a piston that's called stepidotomy, and even it has miraculous results on table. So similarly, with some patients, they have a microtia, malformed pinna, or there is absence of pinna, ear canal is not present, and those candidates are ideal for bone anchored hearing aids. So now we have stickable. I mean, there are companies like Medel and all. They have come up with bone anchored hearing aids. We just stick over the skin. They are called adhere. So it fixes on the skin. There is no need of a surgical intervention. And sometimes one-sided, single-sided, profound hearing loss, sensorineural hearing loss. Even in those cases, bone anchored hearing aids are very helpful. As far as surgical, this sensorineural hearing loss is concerned, so either it is to be amplified using a hearing aid, or else if it is not amplifiable using a hearing aid, then we go ahead with cochlear implantation, provided there is a cochlear nerve present. But if cochlear nerve is not there, then ultimately brainstem implant is the only solution. So now there are few special situations, like sometimes patients present to us with sudden loss of hearing in ear. So they are called sudden sensorineural hearing loss. And how do we define them? If there is a 30 decibels or greater sensorineural hearing loss over 3 contiguous audiometry frequencies within 3 days or less, so it accounts. There are patients who come to us with this kind of. It was very common during COVID times. And usually it is called idiopathic sudden sensorineural hearing loss, but usually viral or vascular phenomena are considered as the etiology. And normally 50 to 70% of the patients, they resolve spontaneously. Whereas we give them steroids, either oral or even intratympanic steroids, to expedite the process of recovery. But sometimes they may not recover also. And it is usually 96 to 99% patients, it is usually unilateral. It does not involve the other side. And the causes could be infection, normally viral infections, trauma, vascular and hematological, and ototoxicity. These are usually the common causes of sudden sensorineural hearing loss. The cancer patients receiving ototoxic chemotherapy, so they can come up with this kind of situation. So next, please. So this kind of sudden sensorineural hearing loss, at times it is associated with the tinnitus, which is the ringing sound in the ears, and vertigo also. And there is a condition called labyrinthitis, acute labyrinthitis, which is very typical. Patients will present with sudden hearing loss, ringing in sound, loud ringing, and incapacitating vertigo. So that becomes an emergency. We have to evaluate those patients using that examination of ear, and using audiometry if it is an adult, and other neurological testing. Like we can go ahead with, if it is an asymmetrical hearing loss, if only one side is involved, which is usually the case, we go ahead with MRI, also contrast MRI of brain, to rule out any space occupying lesions in the cerebellopontine angles or in the track of vestibular cochlear nerve. So so normally steroids, antivirals, and hyperbaric oxygen therapy is usually the treatment which we give. So as far as I am concerned, any patient who presents to me with sudden sensorineural hearing loss, all causes ruled out, I straight away go ahead with intratympanic steroids, because what I want, and early presentation is there, what I want is a higher concentration of steroids in the inner ear, and secondly to avoid systemic, because if we give oral or IV antibiotics, there will be systemic side effects which steroids cause. So my concern is higher concentration in the inner ear and avoidance of other systemic adverse effects of steroids. So I prefer even as primary as well as salvage therapy as intratympanic steroids. So this patient, I mean, this was probably a couple of days only. This patient presented. If you see the first audiogram, there is a dip, and after second injection, the hearing improved. If there is a improvement in 2K, she's undergoing treatment right now also. So hopefully her recovery will be normal. So then, as far as this occupational health is concerned, there is a term called noise-induced hearing loss. And it is very surprising. Probably, I mean, most of us don't know about it. It is the second most common cause of workplace-related injury after, the first is, of course, accidents and trauma. This is the second most common workplace-related injury. So some countries have implemented strict policies to prevent occupational noise-induced hearing loss, and use of protective devices like earmuffs and continuous, audiological monitoring. So that reduces the risk of this thing, the noise-induced hearing loss. So hearing aids, as far as this hearing aids are concerned, so we can have soft sounds, they amplify the residual hearing, and we listen to the sounds. And now we have hearing aids which are multi-channel hearing aids. They cause noise cancellations, and they are with chargeable batteries. I mean, very easy to use. They have the basic parts of a hearing aid: a microphone, amplifier, and a speaker. So I won't get into the details of how a hearing aid works and all. I mean, a general overview. So in children or any adults who have severe to profound hearing loss, and who are not the sounds which are not amplified by using a hearing aid, we go ahead with a device called as a cochlear implant, which is a surgically which we fit in surgical. It has two parts. One is the external part, which is called the sound processor, and the internal receiver stimulator, which is implanted under the skin, and the electrodes go directly into the cochlea, scala tympani of the cochlea, which directly stimulates the cochlear nerve, and we listen to the sound. So what cochlear implant does is it basically the electrical signals, they directly stimulate the auditory nerve, and we listen to the sounds. This is how a cochlear implant works. So as medical professionals, I mean, awareness about hearing loss is very important, particularly in children. That is why a need of universal neonatal screening program was thought. So it came into existence because it affects their life after they attain adulthood, and their career and development and speech and language and overall employment, and it has impact on their overall well-being. So pediatricians who become the referral centers, they have an important role in identifying early hearing loss, and of course referral to audiologists and otolaryngologists, and they become part of special programs. Then this is very important. Pediatricians have a role because they're the first contact point. particularly neonatologists. They are the people who are the first ones to identify, because they subject the children to autocaustic emissions. So they are the people who are first to know about it, and of course finally refer them to the concerned specialist. Thank you very much, and I wish I mean, this is because I think the rural part of our country is in dire need of this such program to lower the burden, because ultimately it has implications on overall, development of the country. I mean, once a child grows with normal, normal functions, and so that he can perform, so our country will develop only then. Thank you very much. Thank you very much for this opportunity.
Thank you, Dr. Noor, for sharing your comprehensive knowledge and expertise in the area of hearing loss. I hope the audience here and the YouTube channel, as well as other social media, will gain a lot, because this recording will also be played on the YouTube channel of Enoch DigiConnect channel of YouTube. I have a few questions related to what you discussed here. In India, as you mentioned, that universal screening for hearing loss for neonates is essential. But what is your experience in getting patient children, especially? What is the earliest age that you are getting?
No, any hospital born delivery usually, I mean, because I am working in a corporate setup here, every delivery we subject children usually between 24 to 72 hours. We subject them to autocaustic emissions. And if there is a problem, we again subject after 2 weeks. We tell them, we emphasize on this aspect. But unfortunately, the concern is of rural India. If you talk about district level or sub-district level, or community health centers, this needs to be all institutional deliveries. We need to focus on this point, and we need to spread awareness to at least medical professionals that this is of utmost importance, because this is ultimately it will become a burden, health burden, and the child who has hearing loss, and if it is not identified at an earlier age, it will become his speech and language development will be affected, and ultimately his performance in the long run.
True. The related issue is how could the mothers prevent hearing loss in their newborn babies? Is it possible to prevent? You mentioned
Yes.
some mention was made about infection and other aspects. Yes.
Normally these things are taken care these days, because if you see, I mean, most of the obstetricians, they tell the mothers to get a torch test done for this toxoplasmosis, cytomegala, all infections which are carried to the neonate. So they are usually done. So they are called preventable hearing losses. But again, as far as this rural part of the country is concerned, there are still places wherein institutional deliveries are not happening. So unfortunately, we need to even these we call them DAI or ASHA workers. We need to educate them regarding this part also, that these tests are important to lower the risk of hearing loss in pediatric age group, because these are the only things which are important. And another thing I would like to emphasize, since you have asked, in pediatric age group, children who have meningitis,
Yes.
cochlear ossification sets in very early in them. In those children, if we identify hearing loss, we need, even if we don't go for at least cochlear implant at the same stage, at least we need to cannulate the cochlea so that the ossification does not happen. At a later stage, we can implant them. So that is of very utmost importance.
Oh, that's very important and useful information.
Yeah.
Because meningitis is not that uncommon in pediatric age group.
It is common.
Yes. Now I come to the young, teenagers today. They are so used to having hands-free and microphones and very loud voice, and music and media is the essence of life today.
True.
And you would see even when they're traveling, they are listening to music. So noise and music cannot be separated. So what would you advise to young teenagers and young adults to prevent hearing loss in their life? Is it possible to prevent that?
Yes, I mentioned about if you, you must have gone through all the slides. So I mentioned about noise-induced hearing loss. So noise-induced hearing loss, I mean, one of the causes for, at times there is a sudden acoustic trauma that can cause noise-induced hearing loss. But if you talk about chronic noise-induced hearing loss, that is because of the persistent noise we are exposed to, our ears are exposed to. So these loudspeakers, these headphones, we are subjected to for a long time. So they can cause this noise-induced hearing loss. In those conditions, we have to subject them to audiometry, periodic audiometry. Those particularly, there are some professions which require these kind of, like a few call centers, and there are people who are working in industries where there is a persistent noise background. So there is a peculiar 4000 dip in audiogram, which suggests that there is a noise-induced hearing loss. So that can be prevented, and use of earmuffs in noisy surroundings, avoidance of overuse of these headphones and microphones, and subjecting our ears to loud music and loud noise. So all these things we can prevent noise-induced hearing loss.
One of the questions that one of the attendees had asked Dr. Rahul Patole, any suggestion or advice on PWD candidates' placement with hearing loss in the industries? What would be your thoughts on this?
I would recommend mainly two things. It is a general statement to all industries, basically. Use of earmuffs when they are working in the noisy surrounding, and 6 monthly audiogram. If there is an early onset, we need to switch to some place which has either no noise or less of noise. So that's the only thing which we can do.
Right. Another question has come from Dr. Rajesh Gupta. In newborn baby in the rural setup, how to test for hearing loss?
In newborns?
Yes.
Again, in rural areas, again, audiologist has an important role. District level usually, or sub-district level, we usually have an audiologist. And what we do is, there is a machine called as otocaustic machine. Otocaustic, there is a probe which goes inside the ear after examining by the ENT surgeon. So there is a probe which goes inside the ear. So if within 24 to 72 hours, it shows refer. There are two basically results are interpreted, either refer or pass. If it is pass, it is fine. If it shows refer, then we have to again subject them to otocaustic emissions after 2 weeks. If again it is refer, then we have to subject those children to brainstem evoked auditory response. I mean that BARA test, which we call.
Yes.
So that will show us the degree of hearing loss in those children, and again accordingly we intervene.
So that's a very useful strategy. The different layers. One could do the screening with not that much expertise required.
Yeah.
Another thing which must be bothering you is the dearth of competent audiologists in our country.
That is true, very true.
What is the plan that corporate hospital like yours is a big chain in the country? How it is helping in developing audiologists
it was a problem earlier. Now there are people, and I mean it was as a branch also audiology. I mean not many people were aware of it. Now it is a very well established branch, and there are many centers in the country who offer bachelor's degree in audiology, even masters also. There are people who are doing even post this PhD in audiology also, and it has a lot of scope. And most of the places they lack audiology, even district levels. So there is a huge opportunity for them as far as this employment and jobs are concerned also. So this is how we just have to aware people that go ahead. You can go ahead with audiology also as a career option.
Great. In fact, that should be a preferred option, because the demand supply gap is there.
Absolutely.
One of the question that Dr. Madhuri Debsiddar from Goa has asked: can acquired noise-induced hearing loss be treated with cochlear implants in adults?
It depends upon the adults is no contraindication to cochlear implant, provided the degree of hearing loss, if it is severe to profound, we go ahead with cochlear implantation. If it is less, we can go ahead with the hearing aid amplification also.
Great. So there is an option.
Yes.
So the related question which is asked: what is the approximate cost of cochlear implant? And I would add to that: is there in Government of India plan where they fund the cost of the cochlear implant and its surgery?
Yes. So there are if you talk about cochlear implant, there are mainly 3 cochlear implant companies. I mean, the indigenous program is also going on, but unfortunately has not it is not fully functional so far. Trials are going on. So as of now, there are 3 companies: Cochlear, Medel, and Advanced Bionics, which are in place. And if I talk about Cochlear, which is a very standard company, the basic implant costs about 5,80,000 plus 5% GST. Government has put GST on implants, but there are certain government schemes like ADIP scheme, and there are like some foundations are there, like Hans Foundation, where what happens is this government hospitals, they buy implants in bulk, where the price gets there is a significant reduction in price, and even patients are given free of cost cochlear implantation, provided they have to provide their income certificate, and the age of the child should be less than 5 years, and there should be no other cochlear abnormality. Because if government is spending on a particular person or a pediatric age group child, it should be fruitful. If we just straight away go on implanting pediatric age group beyond 5 years of age, usually the outcomes of cochlear implant beyond 5 years are not that great. So it will be waste of resources. So if it is below 5 years of age, and if there are no anomalies, if cochlea is fine, if MRI and CT is showing, it is a feasible process. There are schemes like ADIP it is already running in many government hospitals and private hospitals also.
Right. So there is a choice available of financing from the government funds, as well as if one likes to go on, you can go to corporate hospital and get a choice of cochlear implants. Absolutely. That is what you mean to say?
And it ranges, sorry to interrupt you, it ranges, yes. From like 6 lakhs to around 17.5 lakh rupees.
Very true, very true, yeah. Very true. Another question, leading question from this discussion, Dr. Madhuri has asked: can cochlear implant surgery reverse or give normal hearing levels?
No, it cannot. Yes. It will never reverse it, but it will, after stimulating, because the cochlear nerve is not being stimulated, so the cochlea, the electrode directly stimulates the nerve, so but it will never become normal. The child has to wear a device all through his life. Yeah.
Right. Dr. Rahul Patel has asked at what decibel we should advise to use earplug or earmuffs, and both together. At what decibel levels?
What decibel levels we have to use the earmuffs?
Yes.
If it is more than, I think, 45 decibels, then enough noise, then I think we should go ahead and use that. Yeah.
True. Dr. Madhuri has further asked, any suggestions to reduce incidence of noise-induced hearing loss due to continuous use of earphones in teenagers?
Again, I think this has already been discussed. Again, avoidance of continuous using of these things, and use of earmuffs in noisy surroundings, and that is the only way. We have to avoid using it. It is very simple, and particularly continuous. Over a period of one hour or 2 hours, that is very detrimental.
Yeah, very true. So moderation in the volume level and using good quality hearing devices is another important aspect in preventing hearing loss. In fact, International Telecommunication Union and the World Health Organization yesterday released the standard for the hearing devices. And this is for the first time that global standards have been released. And we hope that in India, cost will not be a factor, quality will be a factor in having good quality hearing devices, especially for the young, because your hearing in the old age group between 65 to 75 years is to the extent of 45%.
Yes.
So everybody is going to, almost everybody is going to suffer from some amount of hearing loss. So prevention is the best strategy, right? Now, level of volume when you are having your, listening to music or any media device, or you are attending any event, that would be the best advice, I feel. Another question Dr. Rahul Patole has asked, is there any provision to get the fitness certificate for PWD candidate from certifying surgeon, or only we require disability certificate from government? What is your view, Dr.?
Disability is fine, but I think getting an audiogram, baseline audiogram done, and based on that, we can give a certificateless.
Yes,
that's not
true. True. In fact, many people I have seen going from pillar to post for getting a certificate from an agency which is recognized for job, because the 1% of the jobs are reserved for hearing impaired as well. And that's a good thing the government has done. They are incentivizing people, individuals with hearing loss. And among the 21 disabilities, it is specific disabilities available today, which was not so earlier. So continued advocacy and support from the entire ENT community has helped the nation to have a national program for prevention of deafness. That is also, I think, important to remember for a country like India, where the advocacy by the body of ENT surgeons has helped the country to start a deafness prevention and control program. So what would be your take on that? How much impact it has made in lowering the age or reducing the incidence of hearing loss?
Of course it does. I mean, just like universal neonatal screening program started in 2006. After that, see, normally without that neonatal screening program, the parents, they would depend mostly on behavioral, observation. They would just see the child not responding to sounds and all those things. But if the same child who's around 3 years of age, if he's identified at an early age of few days only, so we can intervene, because if mind does not hear the sound, the language or speech will not develop. So ultimately, it will have an overall impact on, long run, if you see the career of the child and employment and overall health burden on country. So it definitely.
True. One cannot separate, in fact, hearing with speech.
Absolutely.
If you do not have hearing, you cannot develop proper speech. And speech leads to language, language leads to understanding, and understanding leads to your thought process. And your thought process leads to expression. And that leads to your education and career. So it makes a huge difference. One small problem in the ear can lead, can shatter the whole life of a child or a neonate for that matter. So it's required to be done all through one's life cycle. At this juncture, I would like to invite anybody from the panelists to ask any question, comment, or anything that they would like to say. Just unmute and speak. Dr. Kishore Parekh, want to say anything? Yes, Dr. Kishore.
Malik sir, good evening.
Good evening, sir.
It was a very excellent presentation and very excellent overview.
Thank you.
Based on your experience. But sir, being an occupational health physician, we are more concerned with NIHL, that is noise-induced hearing loss.
Yeah.
And it is a notifiable disease as well as the compensable disease. So most of the management, they are worried about deafness and the legal aspect in the industry. So sir, I would like to ask you, have you come across such cases or any compensable, how it is given or something? Is there, you have any experience in this field?
I have been to, we have had camps in few of the, corporates wherein we have screened a lot of people for noise-induced hearing loss and advised them regarding this. use of earmuffs and avoidance of persistent noise. So definitely, and advise them, regular monitoring with audiograms, and if a person has already, set in some hearing loss, so we advise them to, change of place, or to a place where there is a less of noise, or there is no persistent noise. So this is how it has happened.
Because what we do being an occupational health, we just report to a periodical medical check we are doing.
Yes.
And every 6 monthly or yearly, based on the policy as well the fact check, we do the audiometric test.
Okay.
So what we do, we just inform abnormal cases having audiometry abnormal, either severe, moderate, profound, whatever level of deafness. We just inform to report to the management. Finally, the procedure is very lengthy. It will go to the legal aspect and not many government or whatever. So, sir, what I want to know, is there any case you have come across regarding compensation and all this?
No, not as of now.
Okay, because it is usually done by the government authority. That's why.
Yes.
Huh?
Right.
Okay, sir.
Dr. Noor, another question has come up from Dr. Vikram Rajput. What are your views on issuing driver's license to deaf persons?
No,
Interesting.
it's a very interesting question. I was just,
Yeah.
I have no clue about it.
Yeah.
Probably, I don't think it is advisable to give driving license to a person who cannot hear, because if somebody is continuously honking from behind, and the person is not able to hear, I don't think it is advisable to give
Right.
driving license.
True. Dr. Kamala Partyal is also attending our webinar today. I would request her. She's from NHPC, and we welcome her on this World Hearing Day. Dr. Kamala.
Thank you, Dr. Sam. Thank you very much. Thank you, Dr. Malik, for a wonderful session. It was, I think it was enriching, because we don't have that much knowledge about deafness, especially in children. And I have come across well-read people, our employees. In fact, I had one of my employees who was shocked when he saw his 3-year-old child was not responding to the television, which was in a high volume. So that's when he realized that there's something wrong, and he was very upset. So you're very right. I think the child was born in a hospital. I don't know why the child was not diagnosed for hearing problem. So we indeed do play a very important role in this. And I also wanted to ask you one thing, Doctor. We come across patients, those people who have, wax in their ear when they get their syringing and all done. Their hearing becomes, they are not able to tolerate high decibels of volume. So do you have any inputs on this, Doctor?
Yes, for sure. Now, one thing is, now syringing is an obsolete procedure, and usually wax removal, because this is again a genetically determined thing. Some people may not have wax, and some people will have accumulated wax in the ears. Normally it should be removed under using a microscope or an endoscope under vision and using a suction machine.
Okay.
That is one thing. You know what happens? The patients who have bilaterally blocked ear canals for a longer duration, and after removal of wax, when they are suddenly exposed to noise, they feel, sound, they feel it to be as noise, and it becomes intolerable for some times, but ultimately body adapts to it.
Okay. Thank you very much, Doctor.
Welcome.
Thank you.
Dr. Tyagaraja, I'm finding is also in the panel here from Bangalore. Dr. Tyagaraja, would you like to ask any question or make comments? Dr. Tyagaraja may unmute, and if you want to make any comment, you're welcome to make. Fine. I think he is very contented with the knowledge that you have shared. And within no time, I'm finding we are almost touching our deadline of completing 1 hour. As you know, as we started with music, so we would like to end with music again. And yesterday in the WHO launch event for the World Health Organization, World Hearing Day, it was Ricky Cage who was moderating the launch event at the global level. So here again, Ricky Cage for you.
I feel the strongest of emotions in those whispers, soft and clear, rolling sweetly off your tongue and gently into my ear. On those invisible waves, straight to my heart, and then I can hear it, the beautiful sound of life. Can you hear that beautiful sound of life? Of life. It's in the calming of the ocean and the laughter of a child. It's in the songs throughout the ages and every creature in the wild. And it's in the thunder and rain. It's there in everything. I can hear it, the beautiful sound of life. Can you hear that beautiful sound of life? I can hear it, the beautiful sound of life. Can you hear that beautiful sound of life?
So, to hear for life, listen with care. Thank you, Dr. Noor, for spending your time with us and sharing your knowledge and expertise in the area of hearing loss. I thank all the attendees in the panel and in the viewers box. I would, if some slides, something has been missed, kindly go to the Enoch DigiConnect channel on the YouTube, where the recorded video will be available for all of you to hear at your convenience. I would also request people to share the link for the video in their social network, in their LinkedIn, Facebook, or Twitter account, and also hashtag hearing for life, which should be used for sharing so that we could understand how it has been shared and you could reach the wider audience. And it's important because life and hearing cannot be separated. Before closing, I would remind you that tomorrow is World Obesity Day, and we are inviting Dr. Arun Prasad, a very well-known gastroenterologist surgeon from Apollo Hospital, Indraprastha Apollo Hospital, tomorrow, 6:30 p.m. So you are welcome back at 6:30 p.m. tomorrow with conversation on obesity management with Dr. Arun Prasad. Thank you so much for your time. Thank you and good evening.
Thank you. Thank you, everyone. Thank you so much.